Dr. Treppel, and to the panelists and all the speakers. What a great day you've all treated us to, and these presentations have all been very well done. So I'm going to talk a little bit about necrotizing fasciitis, a case we had in Brooklyn not too long ago. So we have a 73-year-old homeless male with past medical history, HIV, CD4 level 520, with a vascular load less than 30, hypertension, hyperlipidemia, non-insulin dependent diabetic with past medical history of TIA, BPH, cardiomyopathy, and glaucoma. He came into the emergency room on July 6th, complaining of a left plantar wound and gangrene affecting multiple toes. Said he stepped on a piece of glass approximately 2 weeks ago, causing him to sustain this wound, and he went to Montefiore Hospital, which is in the Bronx for those that are not local, and was told he needed an amputation to the thigh, and he refused that amputation and decided to come into the emergency room here and get, a second opinion. His vitals at that time, 98.1, blood pressure 116/67, 84 beats per minute, 18 breaths a minute, and saturating 97% on room air. The labs, the white blood cell count 15.3 with a left shift 81.9%, H&H 10.5 and 33.1. You can see the hemoglobin A1C at 9.7 as well. On physical exam, we have DP 1 out of 4. The PT is non-palpable. Capillary fill time was brisk to 7 of the 10 digits that were there. Temperature gradient is warm to warm. Wagner grade 3 ulcer. Left plantar medial forefoot measuring 1:1, probes deep to bone and communicates distally with the forefoot. Approximately 3 to 5 cc's of purulence was expressed on compression, and we had an eschar to the surface or the dorsal aspect of the left second digit and wet gangrene to 3, 4, and 5. Also, you could also see the EDL tendon was also exposed. So here's some live footage. You can see it there. Obviously, we have the wet gangrene here. It's kind of demarcating there also, as you can kind of see. You see the swelling there as well, and the wound here on the bottom communicates from the plantar aspect all the way to the dorsal. Here's our pre-operative radiographs. You can see the gas in the fourth and fifth, or the third and fourth interspace there. And also on the plantar or the lateral view, you can see the gas is now almost to the metatarsal, mid-metatarsal levels. So what's our assessment and plan for this patient? So it's a 73-year-old homeless male is presented to the ER with left plantar wound and gangrene affecting multiple toes. The podiatry team is suspecting necrotizing fasciitis, and this is an emergency case, needs to go to the OR urgently. Patient was started on broad spectrum vancomycin, NPO, in the OR for guillotine TMA. So what is necrotizing fasciitis? This is an infection of the skin and deep tissue. It's one of the podiatric emergencies, as was discussed earlier by Dr. DeLamata. And this patient came in, and we were going to talk a little bit about what are the signs and symptoms of this and why we need to move forward with it as quickly as possible. So diagnosing and classification of necrotizing fasciitis, usually associated with group B strep, but for diabetic patients, we can almost always expect a polymicrobial type infection. Score greater than 6 is considered intermediate risk with a 50 to 75% risk of necrotizing fasciitis, and greater than 8 is high risk or more than 75% risk of necrotizing fasciitis. Something to keep in mind is that necrotizing fasciitis is a very rare disease. And even your signs of infection here are not very sensitive. They're specific. So hemorrhagic bullae, hypotension, or the soft tissue gas on x-ray still is not very sensitive for the presence of necrotizing fasciitis. However, it is very specific, so you want to keep this in mind. And again, you can see the Limerick score's sensitivity itself is also not very sensitive and specific. And something to keep in mind as well is that the Limerick score was originally developed by general surgeons, usually for abdominal post-surgical patients, not necessarily for our lower extremity type of infections that we see. So a study that was done relatively recently, published in the Foot and Ankle Journal here, shows that the Limerick score has a strong negative predictive value. However, it is important to remember that patients with diabetes, many of the values that are used to determine the Limerick score are naturally elevated in the diabetic or very sick patients. So it's important to remember that even if you're not getting the score that you think is necessary, if your scores may be elevated, you have to always keep a high level of suspicion. Okay, so here's post the guillotine amputation. July 8th, you can see here, still probes deep. July 9th, July 13th, as you can see kind of the progression while the patient was an inpatient. Here's your post-operative radiographs. Oops, maybe go back one slide. Oh, the last slide is thank you. So swab was done, ID recommended sending the patient home on ceftonir with a PICC line until August 17th. And the specimen that we sent, which we're about to go see here, this is a zoomed in view here. As you can see, this is from the gross specimen that we sent. This is the ulcer here on the 2X, and as you can see, the disturbance in the epidermis here as well, showing the ulcer there. And here's just your necrotic or acellular tissue showing just dead tissue here as well. So because we're at a vascular conference, I think it's important to note, what was needed as well. Here's a duplex ultrasound that we got for this patient that's showing total occlusion of the SFA, mid-SFA, total occlusion of the posterior tibial perineal artery total occlusion, and the anterior tibial 50 to 99. So an angiogram was taken, and the left angiogram revealed, again, occluded superficial femoral artery, occluded perineal, and posterior tibial 50 to 99. As you can see, the AT designated here looks pretty robust, even though they're saying 50 to 99. PT is completely gone, and I don't see the perineal here as well. Thankfully, they were able to perform an intervention with a PTA balloon and able to get the SFA open as well as the posterior tibial. And I think it's important to mention, again, with multi-level disease for these types of patients, they're at much higher risk of mortality. So again, the angiosomal directed therapy, as we see here, Dr. Zhang's patient, again, study out of JVS. This is, again, large-scale meta-analysis, when you can see nicely from the forest plots here, favoring direct intervention rather than indirect for greater wound healing and less major amputation. So when it is possible to revascularize the area that is affected, the patients will do much better. So unfortunately, in this patient's case, he never did return after that time. So we hope he's okay with his PICC line, or maybe he went back to Montefiore at that point. I'm not sure. But we need to always maintain a high index of suspicion with necrotizing fasciitis. However, just because the patient has this, we don't want to give up on saving their limb. So, leave it there with that. Thank you, guys.